Welcome to the Wild Physio podcast with your host, Andrew Wild. Today, I welcome three guests for a physio roundtable, the first of its kind. We've got Geoff Ford, who is known as Be Strong Physio on Instagram, Alexis Léveillé, who is known as No Bullshit Physio on Instagram, Bullshit Physio, and Dr. Jacob Templar, who is known as Strength in Evidence Physio on Instagram. Welcome, boys. Really looking forward to it. And it's been probably months in the making. I feel like we sort of started talking about this maybe late last year. Let's just dive straight into it. And the first question I'm going to ask is pain education. What should patients hear when they come in to a clinic, they see a clinician, and they have pain of some description? I know this is very hard to answer, and there's going to be a lot of it depends in today's podcast. But what should patients be hearing when it comes to pain education? Let's start with Geoff.
I think this is a really tricky one because I've toed and froed in terms of the depth to go into with people. But I think really keeping it pretty simple rather than trying to go into the level of understanding that we like to debate as physios, trying to keep things fairly simple for people, but trying to get the message across that pain does not necessarily equal tissue damage. So we can have plenty of pain happening and you do a scan and there's nothing much showing up on scans. You can also have some scans that show you've got lots of tissue damage and don't have any pain at all. So trying to break that connection. So therefore trying to reduce those fear levels.
You did a really good post recently, Geoff, where you asked other clinicians how they describe to their patients what pain is. And some of the comments were actually quite fascinating, what analogies people used. Are there any analogies that you got from that post from other clinicians that you now use?
Anthony Lowe had a really interesting one about the perimeter fence and going around the house. This is a complicated one and I haven't started using it yet, but that's one that I'd really love to dive into and start to unpack myself. But the common ones that I use, the cup analogy a lot. There are a few issues with it, but the cup analogy basically says that we get pain when our cup overflows, and our cup is our body, what we can tolerate in terms of a totality of stress. And if you think about a cup filling up, as you pour a bit of water in, that's one stress. As you pour in another, that's another stress. So once our body does tolerate a certain amount of stress, and stress is an awesome thing. That's how our body adapts. If we stress it, give it a chance to rest and recover, that is how we get stronger. We can adapt to things. And stress is a good part of life. Without stress, life is boring. But if we have too much of it, that can exceed the capacity of our body, and that's where we can actually start to get pain. And I think for me, the reason I love it is because it can get people thinking about some other things rather than purely biomechanical factors. They start to think about, hey, what does impact my body's ability to tolerate stress? So you can ask someone, hey, like when you go to the gym, some days, do you feel better than others? And they're like, yeah. And I say, well, on those days where you're feeling shit, why do you think you can't do as much as you can on another day? And, they start to go, oh, well, I didn't sleep well, or I'm a bit stressed, or work's been really shit, I just can't concentrate. And that gets them thinking, like maybe pain is not just about biomechanical factors, that we can sort of wind our system up with some of these other things. So I find it's really good for that. And then also, if you just get them to focus on maybe one factor, say, hey, let's just pick one thing, one stress to try and reduce, and see what happens from there, rather than having them think about so many different things that they could potentially start to try to focus on.
Yeah, great answer, mate. And it's great to have you on the podcast. You've definitely got a voice for podcasting. We've discussed this before, and you've got the microphone nice and close today. So Don LaFontaine would be very impressed. Doing well, mate. Jacob, anything to add with the pain education that you usually use?
I use the cup one a lot. I use sensitive alarm system, and then I started using sensitive alarm works really well because of where I work too. I work in a low income clinic where there's lots of violence nearby. A lot of my patients can't go outside for like walks and stuff like that. Like I've had a few where we had like 4 shootings in a weekend, and one of my patients like lived right across the street from where they happened, stuff like that. So that stuff kind of works pretty well, because it relates more to like their life. They may not want to think about it, but they can grasp like the understanding of that. And I started using the cake analogy. Have you guys used that one before? So I heard this one from Greg Lehman, and it's essentially you ask them, so like when the last time you had a cake, do you remember like what was like your specific like favorite ingredient? And you go, well, it's a piece of cake. So there's all these things that go into making your pain experience, but you don't always think about them individually. Like we may see that there's tons of different factors involved. We don't need to change them all to make a good cake. And everybody has different preferences for the cake they like. Or even I'll bring that up, like, okay, picture a piece of cake in your head. Now tell me about the piece of cake. And I bet it's different from the piece of cake that I'm thinking of. So that's how we can discuss like individual preferences will be different. Their experiences with pain, individual factors can be different person to person. One person could have MRI that we think looks really bad and have no pain. And then some people have an MRI that looks really good, but have lots of pain. And I'm obviously the statistics guy, so I'll bring up different things about, and I try and play it into stories of like patients that I've had in the past, because it's easier for patients to relate to that. But the alarm one that I will use too is like, I'll bring up a scenario where like something bad has happened recently near the clinic, and I go, okay, so what happens around that time period? Well, there's an increased police presence, there's more patrols, but as that starts to, you get further and further away from that event, there's less and less patrols, or less and less, information trying to be gathered around the area, and that calms down. But then like what happens when it's a constant, and we get into the talk about like chronic pain, and, the 1 in 4, 1 in 5 people don't stop having pain once the tissues have healed, and all those other things.
I definitely can't use that here in Sydney where I live. There aren't many alarms and patrols going around. Alexis, have you got
that around?
Sorry,
here.
Jacob, go on.
I'm good.
You good? Alexis, you got anything to add? And what are you drinking there, mate? Something purple?
It's lavender lemonade. Some girl brought it to me, and I don't know why it tastes terrible, but
You're so wellness.
For me, I don't use analogies that much. I don't really know why. I think it's just I think the way I use them can be very like it's almost like you're discarding the patient sometimes. Like a lot of patients will react and be like, "Hey, do you think I'm imagining my pain?" So usually I'm more trying to bring about that stress as an impact, because you can do that. Like you can have the same output, which is patients like being more mindful of their sleep or their stress levels, if you just mention that it's part of it, than if you go like you mentioned the possibility that the tissue is not related to it. Because I find like, and there's some qualitative studies that have been done. This PhD student called like ASAP something, did a couple on it, like a couple of qual studies, where they show that even just mentioning that the brain has an impact, a lot of patients are going to interpret that like as you saying that the pain's all in the brain, which it's not what we're saying. It's just it's hard sometimes to communicate when we're saying a lot of things over the hour. So try to use fewer analogies and just cite like random studies that I remember, because I'm a kind of the fun fact guy. So I'll cite the Bingle study where, they see that like even just a suggestion was more powerful than an opioid. I'll cite the Alfalofu study that shows that there's a very strong correlation between sleep and injuries, stuff like that, where people are like, oh shit, that's important too. And I never mentioned that maybe the pain wasn't related to the tissue. I usually mention like, it's when the tissue changes happen really quickly, that's when we tend to have pain, compared to if it happens very gradually, like stuff with related to age tends to be asymptomatic. Because I think that validates it. They're like, we're not saying that it doesn't matter that what's on the MRI. It's more that the fact that it happened really quickly, and then you can pivot into load management like on the second session. I feel like I could expand. I just don't want to I want to answer the question the same way that everyone did. Like, I think patients want, when they're talking about pain science, what they want to know is like how into how much pain they can push. I think that's a very, very pressing question as a patient have. So whenever I have a load management section in my SOAPy notes. I don't know if you guys use SOAPy, right? Just like a progress note. Yeah. So I have one at the end that's just like load management, and I'll have like sports that they can or can't do right now. In my opinion, I always say, like, I'm not your mom, so if you want to do them, you can. I just think it's a bad idea right now. The load management section will be like, okay, they can push into 1 or 3 out of 10 in terms of pain, and if it settles within 5 minutes or something. And it depends on the case, and you can look at some things, but I try to have after like 1 or 2 visits just like a pain pattern. So some patients, like, they don't have pain during and they feel terrible the next day, so I'm going to be more careful with those. But there's some that, like, they have a lot of pain and it goes away immediately. So for those, maybe you can push more, and you kind of find the sweet spot where it works. And usually what I tell patients on week 1, when I see you like in 2 weeks, my goal is for you to know, like, the point where like your pain settles and then it's a little bit better the next time, and we can work with that. Like, we don't want progress necessarily the second week, the first or second weeks, because it depends. Like, if it's a very acute issue, should get better. But in general, I'm like, it's for you to get familiar with the principle, and then we're going to apply that for the long term.
Yeah, and as usual, it depends on the patient, the personality, what their chief complaint is. So yes, I agree. But I think having analogies up your sleeve, if you need to use them at some point, if someone's not understanding what you're getting across in terms of your point, I think that's a good one. The helicopter parent around the playground, I thought that was interesting, Geoff, on your post.
Yeah. Did a couple of guys put that one up, I think, didn't they?
Yeah.
Oh, actually, sorry. I actually used kind of a similar one. I think I invented that one, or maybe I read it somewhere. I just don't remember. It's the Traumatized Child.
Yep.
So it's like, if you get abused as a kid, you're gonna have, like, you're gonna be very fearful around other people, or either very aggressive. And at the time, it might have been an adaptive response. But with time, when you're in public and you're an adult, you can't, like, run away at work when you hear like a mouse or like something falling. So the response has become maladaptive, and pain can do the same thing. And I think it connects because I think a lot of people have had bad experiences as a child, and I've learned that with therapy and all that stuff, that maybe the way they're responding might be normal for them, but might not be the best way.
Yeah, that's interesting with kids too. Like, I've conditioned my daughter fairly well to be like pretty non-reactive to most like things. She like smacks her head on something, and I'm just like, yeah, you're okay. And she's just like, I'm okay.
I'm the same. And my wife's always like, oh, you're right. Or I'm like, no, don't do that. You're conditioning them.
Like, if she reacts, I'll like console her, because obviously that's a key component of like nurturing and stuff. But yeah, my wife does that, and I've tried, put the kibosh on that.
A lot of people think that physios never get injured because we're really good at not getting injured, but it's just not the case. We get injured, and we've all had our injuries through the years. And off air, we were just chatting about a few of the injuries that we've had. Jacob, what's an injury you've had recently, and what was your experience like with that injury, considering what you know about the human body?
Yeah. So, as we all know, we've talked about me being a robot. So I just like view it as like, that's a signal. Like, it's, not anything else. So I've had a flare up of knee pain. Started when I was like squatting like 2 months ago. And it fairly much was like resolved, and I didn't really change much. I like when it first onset, changed like my like to box squats, changed the reps I was doing to accumulate the same amount of volume. I was just doing less reps, more sets with the same weights. And then over the weekend, I was doing my AMRAP set at the end of my heavy sets of squats, and then it kind of flared up from there. And so my AMRAP said I should be adding 10 pounds based on my programming this week. And then I did what's 370 in kilos again? What's that, like one?
Heaps.
Heavy.
So 168 kilos today for 3 sets of 8, which would be like a volume PR for me. And I just like worked up with my warm-ups, and was just like, I'm just gonna full send, like, tissue pain is not damage, and I'm just gonna go ahead and do it. And I'm fine now. It doesn't bother me at all right now.
Have you got
And
any concerns and worries about that knee at the moment, or are you just going to get on with it?
No, I'm just going to be my robot self, because I did a post on this, because like if your beliefs shade like on my story, because like if your beliefs are shaded that like if that's going to be an injury, and I know like I've been lower on calories recently, my sleep hasn't been as good, like the temperature right now is changing here in the US where we live. Me and Alexis live not too far from each other, and so it's getting into spring, so the temperatures have swung up from like the teens in Fahrenheit to like it's like 50, 60, 70 right now. So it's like wicked hot comparatively, and that interrupts my sleep quality.
That's
So
all
there's all these,
that's all relative. That ain't wicked hot. Jeff lives on the Jeff lives on the Sunshine Coast. That's hot.
To me, it is when we regularly have negatives.
Yeah.
You don't have AC?
I do, but I haven't turned it on, my unit on yet. I have central air, fortunately.
Okay. So you're blaming temperature for not being a functional adult?
Yes.
Even I can turn my AC on. Jesus. It's
on
like,
my sleep.
It's like a little button. Okay.
So there's all these other things that I know are impacting it, and I'm I'm just going to train the way that I train, and it's been fine so far, and I made a lot of progress in the last few months.
That's great. And Jeff, any injuries you've had to deal with over the years? Anything that's significantly impacted your life?
I've had a few shoulder needles. They're probably the best to talk about, because similar thing. I managed to try and, like, initially I used to be quite fearful of it, and well, I better not load that up. Whereas I've just tried experimenting with movement a lot more recently. So if something's sore, I go, well, rather than focusing on, hey, I can't do anything, what can I still do? How can I still load it? And I've found that approach is so much better in terms of, maintaining your progress, but more importantly, just mental health wise. Like if you stop training, it sucks. You're like, hey, I want to be doing this and I can't do it. Whereas you can just pivot and go, rather than necessarily focusing on that specific goal, is there something else that I can start working on? Is there something else that I can start building on? For me, that mental process is so much better. And that's what I try and use with my clients, my patients, rather than, focusing on so much, because it sucks if you find out, hey, I can't do my favorite, lift, whatever it is, or I can't do my favorite gym activity, and sometimes there is obviously a way you can keep doing it, as Jacob was saying. So you could just modify the load, modify the volume, the range of motion, the tempo. There's so many factors you can change on it. But then if that's still not working, is there something that you can pivot to do? And I found that really beneficial for shoulder stuff. And then at the moment, I've got a little bit of a grumbly knee, going out with you, Jacob. But for me, I've tried to keep going with it, and it just gets a little bit grumbly, and then that little bit of doubt comes into play, and then I'm like, all right, I'm going to change it up for a while. I'm going to try to calm it down and build it up approach, and it does seem to be working so far, but I haven't really stepped up the load again yet.
Yeah, and the theme's pretty consistent here: modify, don't stop.
Yeah, 100%. And I would say that goes into my approach, like how I manage my own injuries. I tend to be quite aggressive, like therapist, anyway. So like if people are going to go through pain and they're like, I can tolerate it, then we're going to do it. And that's the way that I am with me. If most pain I can tolerate, I have a lot of confidence and feel comfortable in my knowledge. So I'm just going to full send until my body says, no, you can't do this. And then I'll modify it.
But our beliefs do really influence how we treat our patients, don't they?
100%.
That's really interesting.
Alexis, have you had any injuries other than some scratches on your arm from your cat that you can talk about that may have influenced your life? Your mic's off, mate. Jeff, tell me something while we're waiting for Alexis. We good, Alexis?
Get up.
Good.
Yeah.
All right, you're here. You're back.
Okay, do you guys hear me?
Yeah.
You guys hear me?
It's kind of cutting in and out. Sorry for the technical issues we're having here.
We're doing that last time.
They don't have very good Wi-Fi in Canada.
Andrew, have you got any?
No, it's the mic.
Look, yeah, I've had several over the years. I'm built like glass. I've had, bilateral hamstring strains 2 years ago in the space of 2 steps when I was sprinting. I looked into the research and I only found one person that had ever done that. And so that was significant in the last couple of years. And I had stress fractures in my back when I was sort of 16, 17, 18. They consistently reoccurred. And ever since then, every now and then my back gets a little niggly. If I really love trap bar deads. If I trap bar dead twice a week, I'm sweet. That's just something that I use to really manage my back. I play a lot of golf as well, so it just keeps my back and everything really strong. But yeah, 2 years ago when I did the bilateral hamstring strains, that was pretty tricky. For a good week I was struggling to walk. I've got a fair few stairs to get to my apartment. I was struggling to get up and down those. I couldn't put my underpants on for a couple of days. I was using a golf club to slide my underpants up my legs so I could pull them on. And I used to get into bed. To get into bed, I couldn't actually sit down on the chair. I had to like salmon myself down onto the bed and crawl up. So yeah, that was probably, but the hamstrings are fine because I knew that, if I just gave it some time, let it settle, slowly build back into the things I want to do, it was going to be absolutely fine. And the reason why I did them was I hadn't been sprinting much. I went and sprinted with a mate. I got super competitive and I wanted to win. And I just hadn't conditioned myself for sprinting because I hadn't been sprinting. So yeah, shit happens. Alexis, are we back on?
Yeah, it should be working now.
Beautiful.
Yeah, so I've had a very similar injury pattern. First of all, I've had 3 falls where I injured playing soccer. I injured my shoulder and I broke my arm twice. Not my arm, sorry, my hand. Very clean fracture, so no issue. I just had to splint it. But the big one I've had was the adductor tendinopathy. I developed, and it was a really similar pattern to you. So I went to the gym, big training session, and then I decided to do the machine, the hip abduction machine. And I realized I could max it. So I maxed out the machine plus 45 pounds the same day. And then I played 3 soccer games the same day. And I was at the end of the 3rd game, I was yeah, I'm feeling kind of off a little bit. And then I just kept playing. And then I was literally walking. I was hobbling on the field. And I'm playing defender, trying to catch a guy sprinting full speed. And I'm just hobbling. And then the way I rehabbed it, I'm not a very anxious guy. So I think it really helps. I just basically found I had just read the Torborg papers on adductors. So I just did Copenhagen bridges eventually, and then kept playing. And I was really lucky because when I would warm up, the pain would almost completely go away. It's just at the end of the game, I sometimes couldn't finish the game. So I basically did some load management to tolerance. Sometimes I was limping a little bit the next day, but I tried to find a sweet spot. And when I had it, it was pretty easy to manage, and it went away. And honestly, I don't have any. I'm very lucky because I've looked at literature, and usually there's some lingering symptoms for that. None, but I've rehabbed it for very long. I've been doing the Copenhagen bridges before games for 4 years now, even though I've been pain free for 2 years. So it's cool because that's a good example of research and practice coming together. And whenever someone has that, I think it really informs my practice regarding tendinopathies and load management, because I basically did that before it was a theme per se. It was groovy. It existed in papers, but not in mainstay practice. Whatever. It's good.
I think it's quite beneficial to get injured as a physio. I've had so many injuries over the years, and knowing what it feels like is kind of a good thing. I'm currently got a bit of plantar fasciitis in my right foot. Never had it before. Yeah. I did the longest day of golf where we played 72 holes back in December. And ever since then, it's just been a bit annoying. It's fine. I can do everything I want to do. It's just a little bit those first sort of 10 steps. It looks like I've been shot in the leg in the morning. And so it's good to feel it, what it feels like, what you need to do. When it comes to research, Alexis and Jacob, your recall of research papers is just ridiculous. Do you have a list of all these papers up in your bathroom in the shower and you've just got them down so you can remember them all? How do you recall them, and how do you keep on top of all of the research? Because it's pretty difficult because there's just so much out there. We'll start with Jacob.
I actually did a post on this yesterday, my time. Yeah, I do a lot of, I don't listen to music in the car at all and listen to podcasts. So like I keep up on a lot of topics there. I try and listen to and engage with ones that are like primarily research based, and they like bring on somebody that's an expert, or they're like a PhD or something, relevant in science communication. I find a lot of papers there. And then I actually started doing is saving any paper that I read, I save it in a bookmark on my work computer, and I have different folders for each like topic. Like I have a lower back one, neck one, headache. And then if I do a collab post, I also save them in there. So that helps me to keep them, and then I snowball a lot off of those. And I'm a like robotic reader. I think yesterday in the clinic I started with, and I didn't have much of a gap. I started with like 10 papers that I need to catch up on, and I'm down to 2 now. And then obviously just following everybody like us on social media really helps, because a lot of us post papers that other people don't find, and then you find some unique ones off of those. Especially snowballing on articles really helps. And then I'm doing stuff for those people that don't know, Alexis and I are business partners. So we do a lot of stuff where we're making educational posts and courses. So we find a lot of stuff through that too.
Yeah. Yeah, I'd say my answer is very, very similar to Jacob. And that's what I commented when I reshared this post. It's basically the same. I said one thing I do is a lot of like, and I think you mentioned that too, I do like a lot of topic appraisals. So when I'm not sure about a question or someone asks me about something, I just dive into the research. I find a systematic review and then I snowball from there. And that's why I want that to be finished before I open another. That's why I never looked at like breeding research or pelvic floor research, because I know there's a lot of nonsense in there. It's just too long to open, and I kind of get obsessive. But honestly, the reason I can recall those papers this way is just I've always had a good memory. Like it's one thing I've had, and I think there's a part that's genetic. And that big one is just practice. Like I get home and honestly, I probably read papers for like 5 hours a day. It's like not healthy. And I understand not everyone needs to do that.
Yeah. I think there's going to be a lot of clinicians out there listening to this, and they probably hate reading papers, and they don't want to do more than say 10, 15 minutes a day or every 2 days of reading. How do you think they should keep up to date with research when they're not as passionate about research and reading research? Because personally, I don't love reading research. Sometimes it's really hard to digest. It's often very dry. So how does someone that doesn't like reading research still keep up to date? Alexis?
Yeah, I can go off that. They did research on memory, and basically if it's relevant to you, you're going to remember better. We see the same thing for stroke patients. If they do better, if you give them a functional test, that's something that interests them. Like if you want to practice balance and you have like a ballet dancer, probably better off doing some ballet stuff than doing some balance on a wakeboard, right? The brain seems to work the same way. I think they did a study on like baseball, and like the baseball players were much better at remembering facts they'd never learned about if it was related to baseball somehow than people who didn't play baseball. That's like a stupid example, but so you can make it relevant. So if people did just care about helping people, or if they don't care about physio at all, it's going to be hard. And I'd recommend signing up for something like Mass or Physio Network, where they do the review for you, and it's very short, and you can read an article in like 5 minutes. Right? That's really cool. You can listen to a good podcast. Like this one, or like Eric Mera, I think is amazing. Like his podcast is really good, but it can be dry at times. So yeah, listening to podcasts is good, and there's some very short ones, but making it relevant is going to build that, not that passion, but that need, because you see a reason to do it, right? I don't know if you guys have done that, but I went back to school and I had courses that were really interesting, but I had courses that I knew were completely useless for me, and I was like, I'm paying for this, whereas I could be paid like $100 an hour to do something else. Like I'm wasting my time and I hate it. So if we apply the same principle to like digesting research, if you're like, oh, this is going to help this patient, or this is going to help me make this presentation, and then, because I think people like Jacob have incentives of work to do presentations. I think that's useful. So you make it relevant. You see it as a tool to an objective. If you don't like the research itself, like for the sake of research.
And a shameless plug with Alexis and Jacob, your business at the moment, Pragmatic Rehab Principles, is that correct? How do
Yeah.
people get in contact with you guys if they want to start, I suppose, doing your course?
I'll let Jacob
The-
answer.
The best way would be to go through our Instagram right now, because we're kind of getting everything set up on the back end for all that. But that's where we're most active right now, where we're putting out like topic appraisals or like I have a post preview of like 5 important papers if you wanted to get into more treating people with headaches or migraines. Because that's especially like, and like Alexis said, like that's an area in my work practice where it's like I'm incentivized to do in-services and things like that. So like sometimes my bosses come to me and been like, hey, I want you to do an in-service on this specific topic. Can you give us some more information about that? And then I think too, if people follow individuals like us who actually post references to and like relevant references to a topic, like that's a good way to get synopsises and do look at research reviews, because then you don't necessarily have to read a lot of it. And if somebody's really good at actually looking at methods, they'll point out flaws and stuff to you.
Yeah, for sure. And research summaries are really good. You know, the mass, I don't know whether you guys have seen Mass with Greg Knuckles and those guys. I think, you know, that's really good because they summarize the research and they delve into all of the monthly research that's out and break it down in an easy to understand and less dry manner. I just find how dry some of the research is really hard to get through. Geoff, how do you go about it? And you had a very good idea recently. The 4 of us are going to maybe start a little Google Drive with relevant research articles. So
yeah, I think it's a great way to do it because, yeah, probably similar to you, Andrew. I'm not a huge reader of research, but I force myself to do it. So if I'm going to like do a post on something like, you know, core or posture or something like that, then I make myself go and read the research. And I guess that's what Alexis was saying, trying to incentivize yourself to do it. So, I mean, some of the areas I love, like I actually really enjoy reading qualitative research and reading about people's insights into their experience with physiotherapy. I find that's really interesting. Whereas my sort of weakness, I guess, would be, you know, stats and the methods and that side of things, which is super important to understand. But I've just never loved statistics so much. But therefore, you know, I need to go through and I need to like look at it and also try and look to people who have a better understanding. So I love going to you guys and just seeing what you say about the methods and the stats and that side of things.
I think there's no excuse as well now, considering we have so many amazing pages on Instagram. We have so many great podcasts. You can stay up to date and not necessarily sit there for 5 hours like Alexis does and read research every night. There's just no excuse. You know, you need to be up to date, and there are so many mediums now you can use to stay up to date.
I think podcasts are amazing. They're so accessible. And obviously, you've got to choose the right ones, but they're such a good way to stay up to date and at least have an idea of what's going on. And then when you need to, then you can go and delve into the papers. But I would honestly say that podcasts are the main reason that my physio has evolved so far since, you know, when I graduated back in 2016. Even as I was graduating, I was delving into podcasts and, you know, Greg Lehman, Adam Meekins, Ben Cormack, etc. And there's just so many amazing minds out there to tap into. Like I think it's exciting.
I was going to say, I actually have done this for my students, some of my students, and then like coworkers, is there's appraisal tools now too that are really great. Like Oxford has a collection of them. Cochrane has some, Pedro has one. I found the Oxford ones are like the easiest ones, and it'll go through and it'll like walk you step by step through like the method section. And it takes like methods sometimes from being like a 20-minute read to like less than 5 minutes. And you can tell like if they did their methods correctly or not.
That's cool. I'm writing that down right now.
Yeah, write it down, Geoff. Put it in the Google Drive, mate.
Yeah. I'm actually thinking of starting a journal club. I don't know how it's going to be doable like financially because it takes a lot of time to prepare. So
yeah,
I've got an idea. It takes time to set up like everything. I think it could be fun.
Let's pivot this conversation to this now. Do people need to be doing mobility programs? Because I can see so many mobility programs being sold online now. Do you need to do a mobility program? Let's start with Alexis.
It depends. If you want to get more mobile, like I'd say a flexibility program could be useful if you want to do a mobility program, which is kind of different. Usually they do it for lifting and performance and health. I don't think so, but there are like my buddy, Ranger Strength. I don't know if you know him, right? Lucas Aaron. He's one, but and then I'd say like the flexible, like Jeffrey Wolf. Also, like I'd say he sells like strength and flexibility programs. The difference is for people who want to be flexible and strong. Like if that's your goal, that's perfect. But if you're doing it, and the way most mobility program, that's how they're usually sold, is like if you don't do this, you're going to get injured, or if this is great for your health. And there's not a clear link between mobility and health or performance or strength, as far as I know, except if you're doing a sports that requires a lot of it, which is not a lot of sports, to be honest. Like maybe like circus sports or gymnastics.
Gymnastics,
yes. Yoga, but yoga, like the practice is mobility work itself. But other than that, I'd say for health benefit, it's very, very low on the totem pole. So I would say no in almost any case. The only case where I'd say it is relevant would be like very high level powerlifting athletes, where they would want to get more flexible and they've already exhausted all their, like they can't lift anymore because they push too much, right? They did an AMRAP. They're not gonna do like another set of squats to increase their mobility. They can do like the ankle little rockers or whatever if they have a limitation there. I just think after a while they probably don't need it, and most don't need it, especially Gen Pop.
Jacob.
Yeah, I mean, I agree with a lot of things he said. Like our buddy Dr. Joe, who I make fun of for not reading a lot of research, he's works with a CrossFit group, and we've had discussions about this too. And it's like, we don't like to sell it as mobility because like, unless you can't get into position for something that you specifically want to do, like I believe even flexibility has been taken out of the ACSM guidelines now for activity, just because it just doesn't really have a relevance for most general people. And if they're exercising frequently, like you're probably going to be able to do like task specific things. And if not, then we like, because I've worked with powerlifters. I recently left the strength guys. We had a mutual parting where I'm just working on different projects and want to focus my time on that. And then Dr. Joe works with CrossFit athletes, and we've talked about that. Like it's better to add something that's specific to a task, that if you're having mobility issues, do more of that and like time it maybe. Like, so we might have had athletes like get into a squat position and do like the rockers like Alexis was talking about, or hold on to a little bit of weight and get into that stretch for a longer period of time if they want, if they're having an issue with their squat where they're not getting enough dorsiflexion or something like that. But for health wise, you don't need it. And a lot of lifters, like, you develop stiffness through daily activities just because it's an adaptation, and like tendons get stiffer the stronger you get. So it says, hey, why am I going to achieve this range of motion while I barely have any load on me, versus when you normally might squat with like loads that are close to twice your body weight or more.
I think the other thing is we live in a society and a world where most people aren't exercising enough, and then they're thinking they need to go off and do 30 minutes of mobility every day. They're probably better off to do something else, something so simple like walking, or maybe some more regular lifting. I just think it's a bit ridiculous. And I think a lot of people forget that when you hit end of range, you hit end of range. Like you can't necessarily, like, the only way you're going to increase mobility in your hip, maybe if you're hitting end of range, is if people go in and shave off a bit of the bone in your hip, and you're not going to go from like a knee wall of 12 centimeters to 18 centimeters if you're hitting end of range. Like, it's impossible. If bones are in the road, they're in the road. Geoff, you got anything to add?
No, I think that's awesome. I mean, the only thing I'd say is that delving into why people want better mobility, I think, is super important. And if it's for their goals, then obviously it's relevant. But a lot of the time, there's this perception that's been created from a lot of sort of online people back, for probably the last 10, 15 years of saying that you need mobility to feel better and to perform better, which probably for most people isn't necessary. And therefore, if you're prioritizing your time with mobility work, like I've got guys coming to see me still who are just like, I just want to do mobility work. I want to feel better. I want to move to, the animal flows and all those sorts of things, which are cool. But they're also not meeting the basic activity guidelines in terms of their strength training, their resistance training, their cardio, that sort of stuff. So it's about having a chat about that. Like, hey, like, what do you think this is going to achieve for you? And can we achieve it with some of these other methods that you may enjoy more? So sometimes people are just doing it because they think they need to do it, not because they actually enjoy it.
And people forget that you're going to get mobility changes if you strength train as well.
Totally.
If someone doesn't strength train and never has, and then all of a sudden they start doing squats, say for instance, all of a sudden in 2 months' time, it's easier to get into a squat.
Yeah.
I was going to mention that in I can't remember the authors' names, but there was a systematic.
Come on, Jacob, you need to know the author's name, mate.
It's Alfonso 2020. I'm officially better than Jacob.
Just on that,
Alexis wins. That's in the shower. It's at the top.
You're fired from PRP, Jacob.
Till he messages me and says, "Hey, I need to study for this," and then I send him 3 of them. I was gonna say that they did the one where they compared the literature on all the healthy individuals and like compared range of motion changes with stretching versus strengthening, and they found no difference. So it's like, that's my bias anyways with patients. So I go, okay, you want to get your knee flexion better and you want to be able to kneel? All right, we're going to practice kneeling then.
Anything else to add with the mobility program question? No, we'll leave it there. Now, when I did the Insta poll just before we got on the podcast, someone asked, not a bad question, I like this one. So we've known for many years that the ACL can spontaneously heal in some people after it's ruptured. And the person asked, could this be applied to other ligaments? Let's start with Alexis.
Can I deny and let Jacob answer?
If you want.
Yeah, let's go. Let's let Jacob go first.
Yeah, because he's more versed in the literature on this, I think, than I am. I've just looked at the ACL stuff, and obviously, like a lot of people now know of Kieran Richardson.
Yep.
Yeah. So I've read some of the papers on ACL healing, and it's like as papers go on and on, it seems like ACL repairing is getting better. And I remember when I was doing my studies for my orthopedic clinical specialist, there were some of the courses I had to take to prep for that, and they talked about MCL healing is pretty good in the knee because of its attachment to the capsule in the knee, so it has pretty good vasculature. And sometimes in NFL players, there was a few of them recently that like ruptured their MCLs like in the bowl games that they'll have at the end of the season, and then they applied for the NFL draft, and then by like draft time and combine, like their MCLs had healed and they were completely back to sport. I think those are the main ones that have healing. I know we talked about off air some stuff about the ankle, and there's some papers just that were brought up in the courses that I was taking that talked about the hysteresis and the ATFL and stuff like that as well.
Alexis?
Yeah, I'd say the thing about the ligaments, if you look at for ATFLs, I think we only have case reviews so far. The one where we have the most research, and I'd say that's true for most solid research that's been done in physio, is on ACLs. And on ACLs, the paper I think Jacob was mentioning is the Stephanie Philbay 2022 paper, showed like 59% of ACLs could regrow. I don't have access to the full paper yet, but we don't know like to what degree it rehealed. But we know that people who did the best were the people who did get the surgery and whose ligaments healed. But the problem is those are the ones who did second best are the people that got the surgery right away. So in the future, what we hope is that we can find who needs the surgery and who does it as quick as possible. Because the people who do the worst are the people who ligaments did not regrow, who did not get the surgery. The third worst are the people who got the surgery but late. It's a small difference between the early and late surgery. I usually tell people to wait like 3 months to get it. To see if they do better. And we still don't know the overlap between what we call copers, so people who don't need the surgery, and people whose ligaments regrow. I would assume it's fairly big, but not like there's some people who don't have the ligament at all and they're doing completely fine. Like I've had a patient come in and complete tear on the MRI, and she only knew by accident and she was fine. I was trying to hurt her and I couldn't. And I was like, Like you're literally doing like pistol squats and you're fine. You can run, like you can just leave. You don't need physio. So, there's different things.
Yeah, that's a big problem in our literature on that too, is like they're not giving people adequate enough time to see if they're copers, and like doing appropriate testing and strength testing and return to play testing and just strengthening people. Like one of our mutual friends used to work at a giant hospital system, and he was telling me about like the exercises that they have people do, and they're supposed to be one of the best like sports rehab places, and like they would barely have people like doing anything and like not strengthening and just doing like crap. And then no wonder they're like re-tear rates, and like how can you find a coper if you're not pushing them hard enough to actually see if they can develop the neuromuscular control and strength?
I had Tom Cross and Dr. Merv Cross on my podcast. I released it last night, and Tom Cross is currently doing research at the Stadium Clinic where he's doing a bracing protocol for ACL deficient patients. And to start with, it was just an idea that Merv had when a patient came in and had ruptured her ACL, and they were like, let's just try to brace it at 90 degrees and see whether we can get some healing, and it healed. Now, this then from there, the research was born, and now I think they've got 83 patients. I've probably butchered the stat there, but the idea of it is now they've started to classify ACL ruptures, and they're trying to figure out who will be a candidate to brace versus go down the surgical route. And Tom's talked about more of the flip type of bundle where the ends of the ACL are nowhere near each other. They're probably going to be someone that needs surgery versus someone that's had a non-displaced, moderately injured or minimally injured ACL rupture. And they're someone that may spontaneously heal. They may need bracing. So I don't think we have the research yet to indicate on MRI, if we see the ACL is ruptured, which type of ACL needs bracing, which type of ACL needs or may just heal from spontaneous mechanisms. Because we've known for a long time that ACLs can heal spontaneously. There was a paper by Ihara in 1994, and that's up in my my shower. 1994, I think I've got you there.
Oh, it was published in 1996 though.
All right.
But whatever.
All right.
It's different. Yeah, you wrote it in 1994.
Costa Paz and Fujimoto, I think they were two others that they did the same thing where they found that there was spontaneous healing of the ACL. But it's a fascinating listen to that podcast, the second part, and the research will be coming out sort of in the next few months, I think Tom said. So it's exciting because what I think is the most exciting thing about it is the cost difference. It's up to 15 grand for a lot of people to have ACL surgery here in Australia, plus physio, plus follow-ups, all that sort of stuff. Versus if they go for the bracing option, it's only 2 to 3 grand. That includes follow-ups, physio, the brace itself. And the brace is in 90 degrees to start with, and then they slowly bring it out over time. And it's a 12-week protocol. So it's still early days with it. And maybe the bracing protocol doesn't need to be as long. Maybe they don't need to be as aggressive with the degree of bracing. But I think it's really exciting. And Tom made a great point in the podcast. It's really exciting for developing countries as well that don't have access to MRIs, that don't have access to surgeons. They don't have the medical care that we have here or in Canada or in the US, whatever. You could always go the wait and see option. Put the brace on, see whether it works, and go from there. There's always the wait and see. The only thing you've lost if you try this is time.
Yeah.
What do you reckon about everyone having an MRI at the end of it? I feel like it should be based a lot more on function, because if you're doing well and all of a sudden you go for an MRI and you're like, no, it hasn't healed, your expectations moving forward are it's not going to be stable.
I think it's a combination of factors that need to be addressed here. But yeah, I agree that yes, you should be still treating the person, how they're functioning, how they're coping with testing, how they're going with questionnaires, that sort of stuff. But at the same time, I think the MRI is very beneficial because we can see that, as Tom was saying, when they do heal, it's healing back to pretty close to exactly what it was like prior to the injury with some of them.
I think paper. Some of them are a bit variable. I did have a bit of a read of it. I might have to send it to you guys because Kieran Richardson sent it to me. And from what he was saying as well when I spoke to him is that there is variability, and they're not sure that some of them are ending up a bit more lax than before. They may be healing onto just part of the ligament rather than end to end stuff. There's a lot of variability in it, I think.
Yeah, and it's so new, you know, we don't know yet. That's one big thing. And it's only going to get better and better from here. But I think the moral of the story here is, because in Australia, the stats are 97%, I think, of people that do their ACL in Australia get surgery.
Yeah,
so that needs to change. You know, it's up to 50% in most European countries. So that's a big factor in Australia a big fact that needs to change, because it's just too scalpel happy here. And Tom mentioned that there's still a place for surgeons. We still need the ACL surgery. We still need great surgeons, but we probably don't need to operate as often. You're going to say something, Alexis?
Yeah, I have like 2 to 3 things to say. Most of the ACL research, and some of the people are really adamant about like not getting surgery, sometimes forget that most of the research that we have is on isolated ACL tears. So basically the best case scenario. You have at least 30% of people with meniscus tears, and we have no idea if it works in them. So usually as soon as there's more than 2 findings, so like MCL tear or meniscus tear, surgeon is going to operate right away. I agree that for isolated ACLs, we definitely should give conservative rehab a chance for at least 2 to 3 months to see if they can fit within the Coper criteria. Yeah, that's it. The other thing was the Hiraro study. He also did one in 2017. And that's like another example of like how we don't really understand it. You'd think that younger people heal better, but they compared the 20-year-olds to older than 20. And the difference was major. It was like, so 74% of people, never mind, sorry, but the people that were younger than 20, only 13% healed their ACLs like spontaneously, and older people it was like 69.6%. I have no idea why that is. Like, I figure younger people would heal better. Maybe the inflammation response initially is too strong, so the ligament gets like kind of digested a little bit. I have no clue. But yeah, it's just there's so much we don't know yet. Like, and I think we need, like, the point that Geoff mentioned, looking at only the MRI would be kind of myopic, but also looking at the laxity. You know, we know that maybe the ligament doesn't heal the same, but the laxity in isolation is not a predictor of re-injury. So someone can have like a positive lacman, and it has no impact on the risk of re-injury, strangely enough. I can't explain why, to be honest, but we know that it's just not, you need other factors to see if someone's going to get re-injured. And and the other thing was we were talking about the ACLs. Yeah, the other thing, sorry, we should look at also like metabolic factors, because again, like maybe someone who's obese is not, or diabetic, is not going to heal the same as some other people. So yes, there's their MRI, but it's like, what is their body doing? Can they heal on their own? You know, because people with diabetes are not going to heal as well as a regular person that doesn't have it. But yeah, other stuff to look at.
I was going to say that I see in the US that being a big problem is like implementing it, because the US is stubbornly persistent to like, surgeons sometimes are adamantly like almost against like evidence. Like, I'm still having people come in with subacromial decompressions, knee arthroscopies, like all these surgeries that we know like in other countries like just don't get paid for because they're no better than exercise and no better than placebos. And ACL surgeries is like it's like billions and billions of dollar industry here, and there's almost no option given to not do surgery compared to doing the surgery. Like that's all they tell you is like, you're gonna have surgery. And then on top of that, like with meniscus too, I did a review in 2020 on meniscus stuff, and they found that like only 6% of traumatic meniscus injuries actually occur in isolation. So it's like people will have surgeries on those and be like, oh yeah, I felt it pop and this, but like the chances that you would have torn your meniscus in isolation without tearing your ACL is you know, really, really low.
That's a good point.
Anything to add on that? We haven't really kind of delved into other ligaments that much. We focused on the ACL.
Yeah, well, basically only case reviews for other ligaments.
Yeah,
so from what I've seen. I would assume they can heal. If the ACL can heal, I'm pretty sure the ATFL can heal. I'm just not sure how relevant it is for ankles because they tend to be less recurrent than ACLs, from what I've seen.
And it also depends on where the ends of the ligament are. If they're a long way apart, they're not just going to all of a sudden just go and, heal together. There needs to be some continuity or some closeness, per se, of the actual ligamentous tissue for there to be potential for healing. And Tom's talked about that with, if it's a flip bundle, they're probably going to need surgery in the ACL type. So I'm really looking forward to reading the research. No doubt you guys will have it on the top of your list in your shower by the end of the year. Looking forward to hearing your thoughts. All right. Is there anything else you would like to discuss, boys, on this podcast? Anything that is pressing you want to get off your chest?
What about what people should be getting out of an appointment? That was one of the sort of broad topics we were trying to come out with today.
Yeah, what people should hear from their therapist.
Yeah.
Fire away, Geoff. You're up.
I mean, I can't remember the name of the study. You boys will probably help me out, but the one that showed that there's basically 4 things that people really want to hear. It's how long is it? What's wrong? How long it's going to take to get better? What I can do to help myself.
Shout out Louis Gifford.
What's that?
Shout out Louis Gifford.
Is this Louis?
The late great. Yeah, that was his thing.
That was Louis. Yeah, that's right. So I think those factors are super, super important, and developing your therapist should be going through and developing a plan with you to get you from where you are to where you want to get to. And I think for me, a lot of what should be happening comes from the inverse of what shouldn't be happening. Just the too much information that's feeding into fear of movement, kinesiophobia, fear avoidant behaviors, that real catastrophizing. So if you feel like there's something seriously wrong there and you start becoming overly obsessive and concerned about it, we know that those factors, being fear avoidance, that catastrophizing can lead to that chronicity or that persistent pain where it goes beyond that normal tissue healing timeframes. So if we're hearing messages like that from our therapists, then that's just not good enough. We should be abiding by the principle of first do no harm. And I think, honestly, in my opinion anyway, some patients would be better off not going into the healthcare system because they're ending up worse.
Yes.
What do you guys think about that?
Yes. We have an Ahmed physician out here that's he's 85, and I've had to have patients go into him and lie to him about how they're feeling, because if you have any pain, he's going to keep you out of work. And I've had people that are have 3 out of 10 back pain. They're like, look, I can tolerate this. This is fine. I have them in the clinic doing exactly what their work is, and they're able to do it. And if they go into him and say they still have pain, he's going to hold them out of work longer.
That's terrible.
Yeah.
I agree with you, Geoff.
Yeah, that was very good.
I seriously think a lot of people, and 100 years ago, physios didn't exist. People just got on with it. And there's just so much nocebo getting thrown around these days. It's just, it's hard for some people because it's a bit of luck of the draw, because people choose a therapist often based on convenience, and, they might just find a therapist that nocebos the shit out of them. And then they're going to potentially have issues going forward with negative beliefs. You got anything to add, Alexis?
Yeah, I think I agree with Geoff. I was speaking about this with Ben Cormack, for low back pain, I think that we would be better managed as a community. If you have low back pain, you go to this group or whatever, the society, if we were a big tribe, would take care of you and help give you social support and be hey, we're going to go to the grocery store. I know it's going to suck, but we're going to hold your hand or whatever. That would probably be more effective than most physical therapy, as long as, there's a physical therapist that rules out any red flag. They're hey, you're fine. This is going to get better on your own. Just go back to this support group, something like back school, but without the nocebo. It's just, I don't think society's there. So for me, if we're talking about something like low back pain, I see my role as harm reduction. I'm just trying to get the life of the person to be as normal as possible. as they're healing, and making sure that they don't transit into something being chronic. So sometimes that means not seeing the doctor for useless imaging, not getting that useless injection. And it's like, it would be better if I didn't have to do this, but unfortunately, because of the misinformation online and stuff like that, and sometimes people just don't have the support, right? So maybe I'm that support. That's how I see it. But there's obviously cases where physio is very important. Like for ACLs, I think we have a very important role. For injury reduction, I think we have a very important role. It's just, I think we're making up for a system that's just not there yet. And it's normal because the research is just coming out on how to manage it better.
Yeah, I was going to say, that reminded me of paper Barris and Baker from 2009. Was done in the US, Medicare enrollees in the US. The only thing they found that correlated to you getting an MRI in the US was your geographic location in relation to where a scanner was.
Oh, you meant surgery. I know the study you're referring to. You mean surgery?
Yeah, and then people end up getting surgery. But like even with MRIs, they found that just based on where you lived, if you lived closer to one, you were just more likely to get one. And then there was the British one.
Stevens 2021.
Yes, I believe so. I was going to pull the reference because
I'm pretty sure, Alexis, you mentioned this on the podcast. I think the first time you came on my podcast, you mentioned that.
Yeah, it's iatrogenic harms.
Yeah.
I feel like people should leave a consult with a physio or any healthcare practitioner and feel more positive about their current predicament if they have a injury per se, rather than more negative. I feel like so many people leave and they're like, I got this, and this wrong, when they didn't know they had any of that shit before they walked in, and they might not even have that, and they've just been noceboed. But yeah, it's a great point, Geoff. Like a lot of people probably don't need to see a physio, and they just need to be a little bit more tolerant to pain and just deal with a bit of pain. I feel like we're in a society as well now where people think that you need to eliminate pain all the time, and pain is bad. We need to get rid of pain all the time. And the helicopter parent is a good analogy there. The helicopter parent that doesn't want their kid to get hurt at all. Getting hurt is a good thing. It's part of life. If you didn't get pain, you'd probably die, because if you didn't get pain, you'd probably somehow hurt yourself really badly and you can't feel pain, and you bleed out or whatever. You get bitten by a shark and you can't feel it.
The Lancet did some stuff on this about industrialization in countries. Like you tend to see a rapid increase in levels of disability as a country that's not necessarily as industrialized or has a medical system like ours, develops a system like ours. There's a rapid increase in the amount of disabilities that their citizens show, because before they were just going on with life like, hey, like I got bigger things to worry about where I live. Then does my back hurt a little bit? Like they got to go get water, different things like that. And I see that with Nepali people that like come here that are refugees. Like over in Nepal, they're like putting like stacks of stuff on their head and never complain about neck pain. And then they come here and they're like, oh yeah, see what's going on in your x-ray, and now their neck hurts tremendously.
It's probably because they don't do enough chin tucks,
Yeah.
Topical.
Yeah,
a deep neck flexor endurance.
I see. It's funny. There was a recent paper about that, wasn't there? Yeah. So it's so funny because like when I first started practicing, that was all the rage. And the clinic, I'm not going to say the name, but the clinic that I started at, they had a couple of those, whatever you call them, those blow up. It's got a really big name. It's like a spogarometer or whatever it is. And they used to actually give them out to patients to take home to practice their deep neck flexor work. And I just thought, how is that going to help? It's just complete bullshit, taking a little blow up toy home. What did that study actually say, boys?
Jake, you want me to go?
Yeah.
So if you do up to 4 or 5 non-guideline adherent practices, so usually that means useless injection, useless surgery, useless imaging. So that means like in the absence of red flags, your risk of transitioning from acute low back pain to chronic low back pain goes up 53%. So basically, the more you do, the worse you are, if it's not necessary. If you have red flags, surgery, it might be necessary, right? If you have like a coda equina or something that's compressing your spine, you do need surgery. Like, I'm not against surgery. It's more that for surgery, we need to do it when it's relevant or when the pain has not improved after a few months.
Yeah.
Yeah.
The one iatrogenic arm one too talked about like the cascade of MRI, and they found that like it was a crazy high number of like PCPs and stuff that were not adhering to like imaging guidelines in the UK. And it was like something like between 60 to 90% of them would like order imaging just essentially because they weren't confident in understanding management of like a musculoskeletal injury. And it was against the specific guidelines that they've been taught on and like given too. And they like kind of even knew that they were going against them.
Oh, okay. Have you seen the one on the doctors with the specialized interest in back pain? They have worse results and they adhere to clinical practice guidelines less. I don't know about you guys, but that confirms all my bias. Whenever a doctor's been like, oh, I need like a specialist in back pain, and it's like, oh yeah, you have like acute low back pain and you did an MRI day one. Like, okay, I'm sure he's a super expert.
I love the generalists because they're the ones that I've had experience with, like the pediatricians, the GPs, the neurologists here will like admit to you, like, I don't know anything about this, like help me with this.
Yeah, but that one was specifically about GPs who say they have an interest, which is different than a specialist.
Yeah.
For physios, it's the same. Like a lot of like whatever specialists don't know shit about that thing. They just have a lot of those patients, but that doesn't mean they're good.
Yeah. That's how I feel about my headache patients that come in with headaches and migraines.
Do you call yourself a specialist?
I'm not the specialist, like in our system. I'm like the guy right now, but I'm trying to get more people involved, and so that I'm not just the person.
Headache guy. Yeah. But
do you guys like a headache?
Do you guys think we've still got a role at, I think that bad physio, they'd be better off not going to a bad physio, but do you think we've still got a role for the right person that is, maybe they are fearful, maybe they're not participating in their normal activities? Do you think we've got a role there as almost like more of a coach and a supporter, and like what you were saying, Alexis,
100%
support network?
Yeah, I've got 2 or 3 people right now that like that's pretty much what I'm doing, and I'm just trying to push them out of the nest and give them some skills. Like they essentially have no problems, but I'm just essentially I'm a big exercise shill and teaching them how to work out and not be fearful.
Yeah.
You know what would be interesting with some people that just have acute back pain, they've never had back pain before, is going to a therapist and the therapist can't talk. And the person comes in and literally just tells their story and then leaves. And they just get everything that they're worried about off their chest. And then they leave. The therapist can't say a word. What would happen there? Because they're just literally getting someone to listen to their story, because often they're not being listened to by other people, doctors, their partner, their friends. That'd be interesting.
Probably get
I think
better.
it's been done. It's been
Adrian
done. That's
Lowe.
called it's active listening. They often use that as a control group for pain science education studies. So they either do placebo education or active listening. And it seems to work the same as the portion of pain science education. So there is at least studies that show an effect. But yeah, Adrian Lowe did some studies like this.
Yeah,
I think it would work.
I think it was like 2019. It was like evaluation as treatment for lower back pain. They found that the subjective histories taking had more of a effect on somebody's like ability to like pressure point. It might have been pressure point threshold, flexion or straight leg raise tests, and was like one other test, and it had like very meaningful differences compared to their baselines. And then like the examination and treatment didn't have as much of an effect. And then you could snowball off of that too. And like I think his name is Mitchell Gibbs. I feel so bad because we talk on Instagram now, and he's an exercise physiologist in Australia, and he did a study where they took a generalized or what was thought to be an individualized program for people with back pain, but they gave them the same program, and they all still got like better at the same amount. So like we could put duct tape over your mouth, practice your breathe, do diaphragmatic breathing while they're in there, and then just give them a general program and they'd probably be fine.
Yeah.
I just came up with a new analogy, actually. I think I use the coach analogy a lot, but I think one I prefer would be the tourist, like the tour guide, not the tour guide, the travel agent, right?
Yeah.
So not everyone needs one. So people could just go to a country and be fine.
Yeah.
But like, if you want to go to North Korea, you probably need like a travel agent because it's dangerous. You might you could do it on your own, but there's a high risk that you're going to go to prison or get in trouble, right? If you just walk in there yeah, but there's some places where a role is more relevant. But like if I'm going to the United States, I don't need a travel agent. I've been before. Like if you have a history of injury and you got a good physio, you know how to manage it, right? So it's like not everyone needs one, but when you need one, a good travel agent is very useful. So I think it's more about redefining a role and where we can shine. So like I gave the example of ACLs. A role is extremely relevant, and a good physio can really make a huge difference. But if we're talking about managing very simple stuff, like stuff that has like a very natural history. So if we go to the extreme, I don't know, like colics, like obviously we don't need to treat that, right? It goes away in 12 weeks. That's for kids. Physios don't usually do it, but chiros still treat that. So that's like in the garbage. But there's, again, I think we need to find an equilibrium. And I think a lot of conditions could be handled in like 1 to 3 visits, whereas it's usually handled with 3 visits a week for like weeks.
And that's often pressure from a business and the people higher up to get the clinician to see people more regularly for it's a business tool.
Yeah.
And they've got to reach their KPIs, and their performance is based on how many times they see each client rather than just getting their clients better. It's a broken model that.
Yeah, which I like where I'm at. I'm incentivized actually to get more new patients. So if I'm discharging my patients and not seeing them as much and seeing more new patients, that's where I get rewarded, because they're like, hey, we want to get people in and out as quick as they are able to, and then you can see somebody new. And on top of that, like you mentioned, the travel agent, that's a good one too, because they're going to know the lay of the land and they're going to give you like the options too. Like, and that's the mistake people make with evidence-based practice. And I have to talk to students about this and coworkers, like, hey, the patient's preferences don't hold equal weight to what the evidence says. Like, we should be starting with what the evidence says is best, then like giving our experience based on the evidence, and then within that, give the patient the options of like, this is what the evidence says is probably the best, especially if they don't come in with preconceived notions or like, I really want this or that.
Yeah, that absolutely. Funnel, isn't it? I love that funnel.
Yeah,
I love it too.
It's been a fascinating chat, lads. Love it. We'll have to do it again soon. Maybe we'll have to do a monthly roundtable. If it's not a roundtable, it's a podcast. Let's just catch up to have a chat. And Geoff, I love your idea. Let's get that Google Drive humming.
That'd be awesome. Love it, guys.
Sounds good. Where can all the listeners find you, Geoff?
Instagram is where I'm most active. Be Strong Physio. I'm on Facebook as Geoff Ford Physio.
Jacob?
Strength and Evidence _physio on Instagram, and Pragmatic Rehab Principles on Instagram.
Alexis?
I'm a No Bullshit Physio on YouTube and Instagram and Twitter. Big thing though I want to drop is I did a huge poll to know who should go on Joe Rogan to dispel some misinformation, and Adam Meekins won like by a landslide. I think he won by like 69% or something. So I'm gonna make a petition public like on change.org in the coming week probably. So people are gonna want to go vote for that. That'd be cool because we need some traction, because I'm just one person. We need a lot of voices to make that happen.
Such a good idea. I love that.
Amazing.
That would be phenomenal.
Yeah.
Can we all go?
People were like, why don't you suggest yourself? I was like, I'm not accomplished. Adam is, whatever.
Yeah, I don't have enough followers.
Yeah, as well.
Although I think my strike violation got taken away, because that's why my engagement has been better on Instagram.
Cool.
You got pulled off Instagram for a while.
I got a strike for a meme that I posted because they said it was inciting violence, because I said I didn't care about.
It was. I killed people because of it.
Yeah. I said I didn't care about the profession, and that if we needed to, I would dismantle the whole system if it meant it was better for patients, and somebody reported it.
What?
It was probably Sean Gibbons. Whatever. Obscure drama.
Well, thank you for your time, lads. Thoroughly enjoyed it. Let's do it again soon.
Yeah.
Yeah, it was great.
Yeah.
This
Thanks,
podcast is live on Apple Podcasts, Google Podcasts, all the podcast channels. I think it's getting loaded up to Amazon. I don't know. As usual, stay strong.